the group, please press star 6 on your phone to unmute and mute. If you are using your laptop for audio and visual during the meeting, you can control the mute function on the Hangout. We kindly ask that only those who are speaking to the group unmute the device. The DUR board member, please reserve your question until the end of the presentation or may ask in Google Hangout meeting chat. For public comment, if you would like to provide public comment, COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet or email medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after meeting to help us improve our process moving forward. Thank you. And look like we have a quorum today. So the first agenda will be housekeeping and then review and approval of minutes. Has everyone have a chance to review the January minutes?
I'd move to approve the minutes.
This is Neil. I'll second that.
Thank you. All in favor?
Aye.
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 Are there any abstentions? Thank you. So can I, look like we have a housekeeping. Please, Jen.
Hi, good morning, everybody. I'm Jennifer Strohecker, serve as the pharmacy director for the fee-for-service Medicaid program. And do have an introduction I'd like to make. In January, we did have 2 new pharmacists join the Medicaid team, and I'd like to introduce them at this time. Typically, we're in person, so we're able to see each other, but via video, I would like to introduce first Luis Moreno as a pharmacist on the Medicaid team. Luis, if you'd say hi, your name should pop up here.
Hello, everyone. This is Luis, and I'm a pharmacist. I joined the team back on January 4th, and previously I was with Molina Healthcare doing MTM work, and now I'm excited to join this pharmacy team, doing mostly DUR work.
Great, thank you, Luis. And Luis actually has years of experience doing adherence work, MTM, and medication adherence outreach to patients and providers. A new role we've developed on the team this year is actually focused specifically on that, to do DUR work that's focused on various interventions we're developing. And Luis will be primarily focused on that work and support the work of the Medicaid pharmacy team. And then we also have Stephanie Byrne, who has joined our team. Stephanie, would you take a moment and introduce yourself?
Hi everyone, I'm Steph. It's good to meet you. I graduated from the U in 2019, focused in management and interest in mental health and substance use disorder. And I just finished up last year my managed care residency, PGY1 with Select Health. So hi Cody, good to meet you all.
Okay, thank you both Stephanie and Luis. So you'll see them at our meetings and presenting topics in the future. So we're really excited to continue to grow our pharmacy team and know they'll have excellent contributions to the work we're doing. The second announcement I'd like to make today is that there was a unified PDL study that was conducted last year, and I really wanted to recap. I think I'd mentioned several times that we were in the process of evaluating the impact of a statewide PDL or unified PDL, and that would be a unified PDL for fee-for-service pharmacy and our 4 ACO partners. This evaluation was conducted through the second half of 2020. There was a fiscal analysis performed that looked at the economic impact or value gained from unifying the PDL. there was also operational impact that was evaluated. So there was work done with the 4 other pharmacy directors and myself. We worked over several sessions to look at what a unified PDL would mean from an administrative standpoint. The summary of both the fiscal analysis as well as the operational impact was put together in a report and jointly agreed upon with our different groups and then presented to the legislature. I will say that the summary of this found that we actually are already quite aligned with our PDLs. We found that the majority of our PDL was actually already quite aligned. There were 3 pharmacologic areas where we did not have alignment, and those being diabetes. We have inhaled medications such as bronchodilators and things like that. And then we also had immunosuppressives, looking at, oh gosh, I'm forgetting the 3rd category, but with Humira and those drugs. So those were the 3 classes that really showed the biggest difference. And when we looked at this and then also evaluated the administrative burden with alignment, there really ended up not being much of a cost savings through this effort. And as I mentioned, this was presented to the legislature during this session, and further evaluation, if they choose to do that, will be forthcoming. But that was our recommendation, to actually not unify the PDL. So with that, we can take any questions that you have on that, or we can just proceed forward with the agenda. Okay, thank you.
Thank you. The next item on the agenda is P&T committee update.
Good morning, everyone. Next week, we will be reviewing continuous glucose monitoring products in the P&T committee. And then in May, we look forward to reviewing glucagon products. And that's all I have.
Thanks. Look like there's a change in the agenda. The asthma management will be postponed to the later date. So we will be review the ADHD stimulant medication edit with Dr. Stockhecker.
Okay, good morning again. Today, let me make sure you can see my screen. Are you able to see my slides? Okay,
Yes.
great, thank you. All right, so today we, the Medicaid pharmacy team, would like to take a few moments to update the board on our ADHD stimulant policy, and give you some insight into where we're headed in the next few months and get your comments and feedback on this initiative. So I'd like to step back first and look at more comprehensively our pharmacy policy over the last 2 years that is really focused on promoting safety and appropriate use of various classes of medications that have abuse potential. So we started in 2019 really focusing on opioids, and over the last 2 years, we've made a significant impact on the use of high-dose opioids, and also use of opioids in vulnerable populations, such as in children and in pregnant women. Additionally, we've done work on dangerous combinations, specifically looking at the concurrent use of opioids and benzodiazepines. We know that this is a commonly used combination, and we also know that it's related to enormous harm when taken together. We also knew from the baseline that a high proportion of our Medicaid population was actually using opioids and benzodiazepines together. With our work over the last year and a half or so, we've been able to address the concurrent use of opioids and benzodiazepines and bring that down substantially. We were, when we started, in about 30% of patients who were using opioids were also receiving a benzodiazepine. And today we're down in the teen range for that combination. We've also promoted the use and prescribing of naloxone when this combination is prescribed together. And we've worked with prescribers and pharmacies to promote the use and the dispensing of naloxone in this population. We know last year too that we looked at the use of gabapentin and pregabalin as a medication of abuse, and also one that can be used and combined with opioids to cause a high. And with this, we evaluated patterns of use and identified where there were some benefits to putting some edits in place. And we created high dose limits for both gabapentin and pregabalin that promoted safe use within labeled doses. And we also had a number of patients who were receiving gabapentin and pregabalin together, and there is not really evidence of benefit in using them together, minus maybe some cross tapering that could occur. And so we did put a concurrent use edit in place as well, which was restricted the concurrent use of gabapentin and pregabalin. And because of this, we've seen use of gabapentin and pregabalin together come down dramatically. And then the fourth intervention that we're presenting on is around ADHD stimulants. And our efforts around the safe and appropriate use of stimulants is what we're going to talk about a little bit more today. But we implemented policy already with age limitations in place. And today we're going to talk about concurrent use limitations and cross-class use limitations that are being proposed as future policy. So as a reminder, and I know we've covered these comprehensively last year, but ADHD medications are a carved out class of medicines, and they are carved out to the fee-for-service Medicaid benefit. So with that, the claims for the ACO as well as fee-for-service members run through the pharmacy system on the fee-for-service side. That being said, we know when we implement policy in our program for the fee-for-service program, it will implement edits across the entire Medicaid population for ADHD medications. Another thing to note is that ADHD medications are among the top medications dispensed to Medicaid members. And while we have data from last year when this was presented in DUR showing that almost 7,000 patients receive ADHD stimulant medications alone, that accounts for about 42,000 claims by volume. So we also know that among these medicines, probably in the top 10, we have top 10 medicines overall by volume. We have 5 or 6 of the ADHD medications showing up among that list. So it's commonly prescribed and dispensed for Medicaid members, both children and adults. So as I mentioned, we covered this topic extensively last year with the idea that we look at promoting safe and appropriate use of ADHD stimulants. We covered in our DUR topics in 2020 in February, appropriate use of ADHD medications in children, and then in March, ADHD medication use in adults. And from this, the question we really had again was, what are our opportunities to promote safe and effective use for ADHD stimulants among Utah Medicaid members? So from this, in July, we implemented our first edits on ADHD stimulants, looking at safety edits for very young children. And with this, we actually took labeled recommendations from the package labeling, as well as the standards established by the Florida guidelines. And we developed very young age edits for very young children under 4 years of age. And then for children under 6 years of age for the designated products that are here. Now, as you know, every time we implement edits, we always look at the population that would be affected before the edit is implemented. We do peer-to-peer outreach, so we identify the patients who will be impacted by implementing new policy, because essentially when we put an edit in the system, it creates a block that requires a prior authorization. And in order to continue care and also provide an educational opportunity to our providers, we always do provider outreach before we implement these types of edits to let them know this is coming and let them know about what our upcoming policy is, the rationale for that, and let them know which patients they have that may be impacted by this policy, and then give them the opportunity to put in a prior authorization if they would like to continue prescribing these medications for their patients. And so, for example, in July, these edits went live. Now, the next step we want to look at is opportunities to promote appropriate use by limiting misuse and abuse. And we know that ADHD stimulants are a class of medications that are abused. And I have some data points here listed on this slide showing that the 2016 National Survey of Health showed that millions of Americans aged 12 and older have misused prescription stimulants by the results of this survey. Many of them are misusing or abusing their own prescriptions. And of course, as we know, these medicines are commonly sold and used by young adults to help with academic performance or just to potentiate a good feeling. There's data down below that really summarizes many, many studies that look at the abuse potential of these products and also their potential for misuse. And so with this, and we covered this topic earlier last year, but as a revisiting of this, we wanted to move forward on what our next steps for improving our policy around ADHD stimulants would be. When we bring this home to our Utah Medicaid population, again, looking at utilization data from last year, we found that of this population over 1 year, from February to February of 2019 to 2020, of those who were prescribed a stimulant, approximately 10%, just over 10% of them, had an ICD-10 code for stimulant dependence, abuse, or poisoning on their profile. So even among our own population, there has been misuse. So what are our opportunities? What we would propose as of April 2021 of this year, well, April of this year, would be for the two things. First of all, to promote safety and appropriate use, we would limit or restrict cross-class utilization of amphetamines and methylphenidates for children who are 18 years of age and younger. And what this will do, the edit that would be built would look back in the system when a claim for an ADHD stimulant would hit the system. It would look back to identify if there had been a claim for a cross-class agent in the last 45 days. It would look for overlap, and it would allow a limited amount of overlap up to 30 days in case there is, for some reason, prescriptions that may overlap as you're switching from one agent to another one, where a person may have stopped one and started another one. So it will allow a 30-day window for changing of therapies or cross-class use, but it will not permit anything beyond 30 days. So it will restrict long-term use. The second proposal would be to create an edit that would limit 3 or more unique ADHD stimulant medications being prescribed at the same time. So again, this edit would work similarly, that it would allow within a 30-day window, it may allow multiple agents to be seen on the profile, but for periods of time exceeding 30 days, it would restrict that. For both of these edits, when the claims are filled, it would prompt a PA required if we were going to, if that was going to continue, and it would require the provider to submit a PA. Now, the rationale for both of these edits is based off of the American Academy of Pediatrics recommendations and also the University of South Florida clinical practice guidelines. And these were reviewed in our DUR board meeting last year. So what does this look like for our population today? First of all, this table in the second column looks at age edits for those who are less than 4 years of age and less than 6 years of age on certain medications. So depending on which medicine you are on, it will hit the 4-year of age edit or the 6-year of age edit based on package labeling. Today, we have 2 patients with 2 different prescribers who are using ADHD stimulants and are under the 4-year or 6-year limit. Now, as we look forward at implementing new policy, as we've refreshed our data this year, we have found that there are 19 patients who will be impacted by the concurrent use of amphetamine and methylphenidate classes for children who are less than 18 years of age. And then for 3 or more stimulants, there were no patients of any age affected by this edit. So what have we done so far to get ready for this? First of all, we have conducted peer-to-peer outreach. Our pharmacists have called the providers who were prescribing the cross-class medications to, again, alert them of the proposed policy and get their feedback on the patients who they were prescribing these to and let them know what they would need to do in order to continue this if they chose to. There was no negative feedback to this. In fact, the providers were happy to hear from us and were welcomed the information we were giving them. And also were actually unaware that, some of them were unaware that this was not a recommended practice to use cross-class. We have also developed a patient-specific provider, or patient-specific letter, and it should be patient-specific and a provider-specific letter. But we have a patient-specific letter. Oh, I'm sorry, a provider letter that is patient-specific that goes out after we have the peer-to-peer conversation. We also fax blast to our pharmacies prior to implementing this, so they're aware of the change and it doesn't take them by surprise if they were to see this edit. Again, we have a very low volume of individuals who will be impacted by this, but it's also for community awareness. We've also developed for the first time a guardian or parent letter that will let our parents or guardians know of this change. And that has been put in development and is going through the approval chain right now. We also, when the point of sale edit will go in place and prior authorization language will be created, which we'll bring to the DUR board prior to implementation of this policy. So with that, that is the summary of what we wanted to present to you around our ADHD stimulant policy. I'm wondering if there's any questions or comments on the information that was presented today. Yes, Kumar. Oh, I'm so sorry, Kumar. We can't hear you.
At the bottom of the screen, if you could click on the red microphone, that'll unmute you.
Okay, can you hear me now?
Yes.
So I was just wondering, this is a generic question, not necessarily related to your presentation. This integration of health department with DWS and DWS and Medicaid functions, does that affect you guys or no?
I don't think we can answer that question at this time. It will certainly impact the Medicaid program, but I don't know how. We don't know how that will impact.
Okay.
Yeah.
Thank you.
Yeah.
So I just wondered.
Sure.
Appreciate it.
Dr. Hoffman, I saw you raised your hand.
Really tremendous work, Jen. I have a question about when you're doing the provider outreach. Do you have a sense as to, you mentioned for the more recent changes that they were educated and received education well. I'm assuming it changed their prescribing practices, but are you tracking when you're doing the targeted outreach? whose provider practices have changed and that they didn't move forward with the prior auth process?
Yeah, we do. It's a pretty meticulous process we follow. We call it our peer-to-peer outreach program, and this was launched with our opioid interventions and carried forward with our antipsychotic in children intervention, and then also with our ADHD stimulant policy updates as well. And with that, Joe, I'll give Joe credit for managing our tables and our data around provider behavior and really looking at how the policy changes prescribing. And also it's a collaborative effort. And Joe, if you'd like to comment on that work, I think it's been so positive in the way that we've been able to alert our community to some changes. And many of them are welcome to change because it's new information to them. So Joe, I want to make sure that's supported by your experience with doing some of this work. If you would comment, please.
Thank you, Jen, and that's exactly right. Dr. Hoffman, that's a very good point, and we always try to monitor changes in behavior of the providers, and we will continue to do so. But thank you for that reminder to do so. To Jen's point, though, 99% of the time when we're able to or once we contact the provider, they're they appreciate the additional data, the additional information, be it on, as Jen mentioned here in ADHD, but on some of the other things, opioids, et cetera. Most providers have so much on their plate that sometimes it's helpful to get just a little bit of additional information, patient-specific information.
Okay, Dr. Weinstein, I see you have a question as well. Thanks, Joe.
Yeah, thank you. A comment and a question. So, yeah, I'm really grateful that we're doing this because I think this is, it's time to tackle this area with the extent of stimulant misuse and abuse that goes on, and even though those numbers aren't big as far as how many patients and prescriptions are affected, that looks like a really good start. I'm not sure where we would go from here. You've heard me say many times, my concern about diagnosis and making sure that prescribing whatever it is we're talking about is accurate. And I know we can only work with the data we have. As far as the appropriateness of prescribing these medications for these indications, and that might be, that might be a bigger problem to solve. But certainly getting information out to prescribers who might not be aware that they're prescribing mixed classes or more than one drug. I mean, for me, it's always shocking to think that somebody might be doing that, but bringing them the awareness and bringing them the information that takes care of reducing those risks. And so, we'll do this and then we'll see, what we can do past that. So I'm very appreciative that we're on this. Sorry?
I'm sorry to interrupt, Dr. Weinstein. But to that point, I should make clear when we make these calls, and it's a team effort, all of the pharmacists and our technicians all pitch in, but we try to be humble in discussing it with the provider and say, hey, this is what the data looks like, but maybe a claim was reversed, or, so maybe our data is not perfect. So thank you for that reminder.
Oh, I understand. I get communications from all quarters, as a prescriber, as most everybody on this call is aware, I do prescribe controlled substances. So I get communications from various entities, and, most of the time it's accurate. Sometimes it's not, but, we understand. I think most of us, as prescribers, understand the intention is safety. And so I think that's really important, but I'm also going to say it sometimes shocks me to discover what a colleague might be doing. So, just in their, as you said, in their haste, or in their, the busy practice might lose track. That's hard to do with controlled substances, though. It's really hard to lose track of what you're doing. I mean, you could write a bunch of antihypertensives with refills and lose track of what you're doing, but it's really hard to lose track of your controlled substances, I think. My question, because I don't want to take all our time, what's the age on the parent guardian letter? I mean, I was just, thinking about where the older adolescents fit in, and how are we handling those communications to parents and guardians with this issue, and the folks who work with the pediatric and adolescent young adult population. Did you have some comments about that? Thank you.
Yeah, so I want to make sure we understand your question. Was it like, of the patients that were identified, so the 19 patients, what is their age span, and is it just a same outreach if it's a 5-year-old versus a 15-year-old to the parent?
So you said there's a parent guardian letter.
Mm-hmm.
I wonder if there was a policy around that in terms of age, at what age that letter, what age of the patient, and are there any different provisions when depending on the age of the patient, because under 18 might still, or 18 or under, or what happens if that, I'm not sure what the status is for an older adolescent who has has decision-making capacity.
Mm-hmm. Yeah, the age that we're looking at for these edits is under 18 years of age, is what this specific letter would be aimed at, because that's where the edits were created. And we had developed one pretty simple, straightforward letter that would just communicate the change and a bit of the rationale. So it was around just acknowledging that we were supporting safety recommendations, and that their child had been identified as receiving prescriptions that would be impacted. So, but it was going to under 18 would be these edits.
I mean, I now put on my parent hat, and knowing what I know about substance abuse, particularly in adolescence, there might be a fair degree of ignorance, particularly in the older adolescent population, but that probably goes down in age too, where, the parent is unaware, right, of what might be going on. So crossing over to the area of use, misuse, and some of the data you put up, if people aren't aware of this, it's pretty stark.
Yeah.
I mean, to children age 12, they're selling these drugs in schools.
Yeah, that's actually a really good point, and one I think we'll discuss that our data would the data would show it is the teens who may be selling, and so yeah, I think your point is a really good one, that yeah, we'll weigh on that, actually. So
No,
thank you.
It's the ages are getting younger and younger, I guess, is
Mm-hmm.
I mean, personally, this was a concern of mine 30 years ago. Now it's a concern again as my grandchildren are hitting those ages. Like these data are getting worse and worse.
Mm-hmm.
But anyway, with interest of time, I'll be quiet. Thank you.
No, thanks for your point. It was a good one. Thank you. Yes, Kumar.
Just in addition to what the doctor just said, I was thinking that there ought to be in your database a comment section where you can record and put down information with respect to findings that you might have, or
Mhm.
explanations you might have. And the advantage then would be later on when your database becomes more sophisticated, because that's what we are hoping, continuous process improvement, then it'll be a lot more useful. So I'm
Yes.
kind of agreeing with the doctor.
Yeah, we do call track each call that is made, whether it's to a member patient or a provider, and those are documented. So.
And are you coordinating this also with the DOPL pharmacy people?
This intervention wasn't coordinated with them. No.
No. Okay. Thank you.
You're welcome. Any other questions on this topic? Okay. Thank you so much. And thanks for the conversation and the points that were made as well.
Thank you. So the next item on the agenda will be the review of the anti-vascular endothelial growth factor. Let me share my screen. Are you able to see the screen clear? Thank you. So this is the prior authorization for the anti-VEGF. So we are having this prior authorization for one of these products really closely to the indication on the package insert. We split it into two of the indication is anti-neoplastic with Avastin, Emvasi, Zybravex, Zimramza, and Zaltra. When the other indication is for the ophthalmic with the Lucentis, Eylea, Macugen, and Bellevue. So this PA is pretty clear when the provider would like to request the indication. They would just look at the indication that approved per package inserts for these products and just circle the medication with that indication. Acknowledge there are the off-label use of some of these products. We have the off-label compendia use additional criteria below that will require one major multi-study or three smaller study published in JAMA, NEJM, Lancet, or other peer-reviewed specialty medical journal with the most recent 5 years. Any compendia use must be supported by American Hospital Formulary Service Drug Information, United States Pharmacopedia, and Drug Information System. And there is an instruction for medical billing, and the initial auth will be up to 1 year, and the re-auth is 1 year. Any question or comment on the form?
Yeah, hey, this is Kyle. I have a quick question, just point of clarification on this. So with the two biosimilars, you have there Emvasi and Zirabev in comparison to reference product Avastin, the ovarian indication. Are we saying then that the biosimilars would not be allowed for that ovarian indication, and that the reference product would need to be used? I understand that they don't have that indication, but some payers actually are covering them even though it doesn't have the indication because they're biosimilar. So I just wanted to clarify that.
Yeah, that is a very good question. Right now, this PA is developed based on the package inserts, but we can only take into the consideration of the biosimilar. If that was the case, I think we would probably have to discuss among the team if there's others, maybe the cost that we can take into the consideration as well.
Yeah, it's a tricky situation because, you know, Medicaid could save some money there, but then again, you don't have the indication. So I don't know. It's kind of a gray area that isn't really discussed a lot. So I don't know. I don't know what to do with it, but I just wanted to kind of get your guidance on it.
Yeah, thank you for bringing it up.
Mm-hmm.
And
do you have a sense of where the payers are covering those biosimilars? What the extent of that is, or why they would be doing that, or I mean, are there Any guidances you think that could be used here?
I'm not sorry. Can you repeat the question, Dr. Weinstein?
Okay, we you know, the other third-party payers, it was just mentioned that some of the other, you know, some of the commercial payers will sometimes cover these biosimilars, and I'm wondering if we have any insight into, you know, why they might be doing that, if there's any, you know, if there's any interpretation of how that happens in the field, if we could relate to that. I don't understand that fully. This is a very complex area to me. Even though I work in the cancer center, I don't understand how those decisions are made. So where you're talking about maybe adding, you know, those two agents into this or more, you know, making this a little bit more broad in terms of what might be covered by Medicaid. I'm wondering if you have a way to understand what the commercial payers do. And maybe it's a bigger question, but as it applies to this.
Hey, Dr. Weinstein, in
Yeah.
our practice, in our experience, the commercial payers haven't really been forthright with a policy. It's kind of just trial and error. And I think they're hesitant to, you know, come out and say, yes, we prefer biosimilars for an indication that they don't actually have. I don't know. It kind of ends up being a gray area. Sometimes sometimes you have success in billing for those and sometimes you don't. So it's hard as a practice to know when to use biosimilars in those indications and when not to because of that. But our experience has been there's just not a lot of information that's offered in that regard.
Right. I thought you might say that, but I thought it was worth asking. Thank you.
For sure.
And it looks like there's a comment in the chat from the representative of the Healthy U, Paul. He said that in Healthy U, they use biosimilar per NCCN guideline. If they are recommended the biosimilar can be used, it can be used in the original product, in place of the original product. And we have a public comment from Novartis, from Dr. Sommer. Sommer, if you are on, please. We have 3 minutes.
I don't know if you can hear her. This is her counterpart. She is going to yield her time. Melissa is, but I don't think she's able to come off mute.
All right, so this is the time for a committee question and action.
Would it be possible under the tables to address biosimilars by saying off-label, biosimilars or compendia use additional criteria?
Dr. Shifro, you want to say off-label for biosimilar?
No, it would be, if you wanted to include biosimilars, you could say off-label, biosimilars or compendia use additional criteria, and then that way, if someone wanted to use a biosimilar, they could follow the additional criteria listed here. If that is something that might be helpful to include that group of medications that are not listed above.
So the National Comprehensive Cancer Network is mentioned here in the chat, and that is a that is an organization of the country's comprehensive cancer networks that annually issues guidance for cancer treatment in the specific malignancies and reviews the evidence, right? And you could consider, aside from the published journals where the studies come out individually, like Journal of the Clinical Oncology, or the abstracts that come out in the meetings, which is where people look at that, and that's how they start tweaking their treatment protocols. Maybe the NCCN guidelines could be added to this paragraph here at the end, as a source of information, as an option. I wouldn't say would have to follow, but since it's a recognized as the national group of experts that make consensus documents on top of the evidence, the most up-to-date evidence.
I think that's a great point. Occasionally NCCN and FDA approved indications occasionally NCCN is more broad than the FDA indications. And in this situation with bevacizumab in the ovarian indication, NCCN just states that a biosimilar is acceptable, even though they don't have those indications. And so, I guess it's a decision of whether you include NCCN recommendations or just strictly comply with FDA approved indications. But I'm with you. I think that NCCN holds a lot of weight and is an acceptable path forward. And in that case, a biosimilar would be appropriate. And so I don't know what you do with that and how you call it out in this document, but I do think that opening that up is advantageous.
Yeah, I was thinking of just using it as a reference source here, not to say people have to use it, but it is a place where the evidence is looked at, and those guidelines are updated annually, where FDA approval, as we all well know, that happens initially, and then for an entity to go back and get things revised is a very lengthy and a process which sometimes doesn't happen, and so the clinical literature will be, there's a mismatch. And so I think what the cancer, what the oncology experts do with those guidelines is look at the trials data, and sometimes they update those recommendations, which supplements or supplants the FDA labeling. So I think that's where maybe that those. So I would say NCCN guidelines at the end of that paragraph, because those are many guidelines for each of those different tumor categories. If people think that's a useful addition there.
Yes, Kumar?
We could add what Dr. Siegfried said and what Dr. Weinstein said. We could add words like, instead of just similar, we could say basis, or we could say please specify, so that the person, right, can have a chance to add to it. And then that way, later on when we analyze, we can pick up the thread. And I agreed with Dr. Weinstein that it should not be mandatory.
Any other comment?
Yeah, I don't know. I'm just reading through this paragraph again just to understand it better, and I think it's good. Like we are allowing, it looks like, off-label use for biosimilars, but the problem with biosimilars is, their studies are to show equivalence to the reference product, and not necessarily clinical trials. Like this is saying you would need to have one multi-site major study or 3 smaller studies. Like I don't know that you're going to get that with a biosimilar unless you're including just those bioequivalence studies. I mean, they're going to have that by definition. So I'm just not sure what to do with this paragraph. Like, I don't know if we're saying, yeah, go ahead and use a biosimilar for an off-label use or not, or where we're trying to point people. So I don't know. This is a complicated issue, but just not exactly sure where it's trying to lead prescribers. I mean, in short, our physicians are comfortable using MVASI for ovarian cancer, because it's a biosimilar, and even though it doesn't have the indication, it's effective and it's the same. But I don't know what to do with this paragraph. I don't know if that points us away from using it or points us to using it.
How about we are just breaking up biosimilar as another criteria, as biosimilar for these will be following the National Comprehensive Cancer Network guideline, and it's just separately from the
Yeah.
off-label and the compendia use.
Yeah,
Would
that'd be
that
good.
be reasonable?
Yes.
Right, because you've got the must in that first sentence on the top. And so if you're off-label or compendia criteria must be supported by these what effectively would get you almost labeling, then the biosimilar would follow something more that's like the NCCN criteria where they're looking at other sorts of evidence and expert consensus, which usually are, those are emerging studies that have been presented in abstract, or they're in the specialty journals, which a little bit overlaps the top, but it's more of a specialty expert review, and I think that that gets you out of that must limitation on the top and covers, I think, what's actually happening in cancer practice. So that may do it better.
Yeah, I agree.
I also agree. I like that separation better.
So do you want to say for biosimilars, you know, is something maybe as consistent with or permissible and you know, consistent with or something like that?
I updated the form. You see the change on the form?
Mm-hmm.
Okay.
Do people like that?
Yeah, I think so. I like that. I mean, you might wordsmith it a little bit. I don't know, but it seems to work now. Are we looking for a motion now on this?
Yes, if I can have a motion.
Okay, I'll move to approve it.
I'll second. Mm-hmm.
Okay, thank you, Dr. Winston. All in favor?
Aye.
Aye.
Thank you.
Aye.
Any opposed? Are there any abstentions? Okay. So the form is passed. The next review will be on the Epidiolex. Let me present that one.
Okay,
I will
so we
read
just oh, thanks, Nan. So we just have one small change to the form. And in red, it's just requiring that labs for the initial baseline numbers for LFTs and bilirubin levels be drawn within 6 months of the approval date. And this happened because we've had prescribers who are submitting labs that were 1.5 to 2 years old before the initiation of the product.
Motion to approve?
Do we have a second?
Someone raised his hand. Oh, or someone else. Doctor.
All in favor?
This is Beth Gargaro. I'll step in. Oh, sorry.
Okay.
Dr. Kier. Dr. Guerrero, did you second the motion?
Yes, I did.
Thank you. All in favor?
Aye.
Aye.
Thank you. Any opposed? Are there any abstentions? Okay. The change you pass. Right. With that, that is the end of the meeting today. So for the next meeting, that will be Thursday, March 11, and we will review the continuous glucose monitoring.
Oh, yeah.
Do we have a motion to adjourn? Thank you, Kumar. Any second? Thank you,
I'll second.
Dr. Winston. All in favor?
Aye.
Any opposed?
Aye.
Abstention? All right. Thank you for coming to the DUR meeting today. Have a good day.